Everybody, this is Dr. Carlo Ojer, board certified emergency physician, and if you're watching this channel, you're watching EDX Video Pro, which is the channel specific for the medical healthcare enthusiast, whether it be a young doctor, resident, medical student, nurse, or anybody else who wants to learn about medicine. Today is Good Friday, and it's good even though something terrible happened. Jesus died on the cross, but it's good because Easter Sunday's coming. So let's remember the day. Today I have a especially good EKG. You can see this. You can see all those tiny little, looks like the teeth on a saw with a narrow complex QRS. Those are the teeth of the saw with a narrow complex QRS. And it looks like there's 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. So 5 of those saw teeth for every one of the QRS complex. And here you have the teeth, but they're a lot less regular. They are irregular. And there's a lot more before narrow complex QRS. So, any ideas what these are? If you do, don't cheat. Put your comments on the section below. Now for the discussion. You ready? Let's go. These tracings demonstrate a bradycardic ventricular response. That means the actual QRS complex are slower than 60 beats per minute. This is in the setting of a tachycardic dysrhythmia. That means the one part of the heart is actually going real fast. This is the atrium, and occurs secondary to the administration of medication that is intended to slow the ventricular response, but that overshoots the mark and induces AV nodal refractoriness. That means that this patient has a very elevated atrial rhythm or dysrhythmia, and he's on medications to prevent the ventricles from going too fast. This patient has too much of that medication, so the actual ventricular rate starts going too slow, less than 60 beats per minute. As a result, most of the atrial waves are blocked. They're not conducting, inducing iatrogenic bradycardia. Iatrogenic is a general term used to mean is doctor-induced or medical care-induced. This transient third-degree block can also occur in atrial fibrillation and is recognized by the regular RR intervals instead of the classically irregular ventricular rhythm. So this is a transient third-degree block. So this is a regular atrial flutter with a 5-to-1 block. And this patient is on calcium channel blockers or beta blockers of some kind, preventing the ventricles from depolarizing at a rapid speed, inducing a sinus bradycardia. This is atrial fibrillation or variable block with the QRS complexes. Now we're going to talk about heart blocks, and this is going to be a longer discussion. That's why I said it's a Good Friday video, because we're actually going to do a lot more than the normal couple-minute video. There are two types of atrial blocks: atrioventricular, which are the more common, and they're more PWIs than QRSs, and there's the sinoatrial blocks, in which the entire cardiac cycles are missing. The AV blocks are divided in the first, second, and third degree. The first and second are incomplete blocks. The third is a complete heart block. Again, two types of block: AV blocks and sinoatrial node blocks. And AV blocks are divided in first, second, third degree. First and second are incomplete, and the third is a complete heart block. Whoa. All right. First degree block. It is a slow conduction from the sinus node to the ventricles. That means the top part of the heart to the middle part of the heart. It is a sinus rhythm. That means there's always a P wave that conducts to the QRS. The PR interval, and here's the big definition, is more than 0.2 seconds. Sometimes you have to memorize some stuff. This is one of those that you have to memorize. The PR interval is more than 0.2 seconds. As you can see here, you have the T wave, P wave, QRS complex. So the PR complex, or the P segment, is 0.38 seconds, which is high. It's more than 0.2 seconds. That means there's a first degree AV block. P waves are not actually blocked, so no QRSs are dropped. Most of the time the delay is at the AV node, although it could be further down in the Purkinje fibers. It has no cardiovascular consequences. That means it's benign. Patient usually doesn't have symptoms for a primary degree AV block. Common in posterior wall myocardial infarctions and resolves as the edema of the AV nodes resolves as well. Can be seen in sinus bradycardia as a result of too much vagal tone, and can be seen as part of the Wenky Back or second degree AV block. So, PR interval, no cardiovascular consequences, is defined by a PR interval more than 0.2 seconds, is usually sinus rhythm, and it happens when there's slow conduction from the sinus node to the ventricles, and it is a benign heart block. Again, let's summarize it again. First degree block is a type of AV block, are usually caused by delayed or absent or inconsistent electrical conduction pathway through the AV node, and is defined as a prolonged PR interval more than 0.2 seconds. Here's another example of a primary degree AV block. You have your P wave, a prolonged segment, and then your QRS, T wave, P wave, and this is the PR interval. Then we got the second degree AV block. Now there are three. Type 1, Wenky Back, less serious. Type 2, and 2-to-1 AV heart blocks. In second degree AV blocks, there's intermittent conduction failure between the atrial and the ventricles. Intermittent is the key word here. Some of the P waves fail to be conducted, resulting in dropped beats. So it's like second degree blocks drop the beat. So second degree blocks, they drop beats. Type 1 is Wenky Back, and type 2. Mobitz type 1 or Wenky Back. It's intermittently dropped QRSs preceded by an increasing PR interval. So the PR gets bigger and bigger until the QRS is dropped. The PR is shortest right after the drop beat. Patients usually asymptomatic with Mobitz type 1 occurs in 10% of acute myocardial infarctions from an inferior wall MI, and no treatments necessary. Let's zoom this in and see what's happening here. So you can see there's a drop beat right here. There's a P wave, but no QRS. Where did it go? And then you got P wave. P wave gets a little segment, gets a little bigger, gets a little bit bigger, and it keeps getting bigger until another drop beat right here. So in Mobitz type 1, progressively big PR intervals until the QRS is dropped. It's clinically asymptomatic, and it can happen in acute myocardial infarctions and inferior wall MIs. Mobitz type 2. This is a serious form of second degree AV block. It is the sudden blockage of the AV conduction without the prolongation of the PR interval. PR intervals are constant prior to the drop beat, so there's not a gradual increasing of the PR interval. The QRS are usually wide and distorted as opposed to the Mobitz type 1, and it's associated with advanced disease of the conduction system. An atrial pacemaker is needed to stabilize the rhythm, and this is the important thing. So this one is the first one of the ones we've discussed that actually needs treatment. Let's zoom on this image. So this is the Mobitz type 1. Let's remember that you get the gradual progression of the PR interval until drop beat. Mobitz type 2, you got the normal P, QRS, P, QRS, P, QRS, and then a sudden missing. And that's more serious. This is the one we're discussing right now. And then the 2-to-1 block. You see the kind of P wave here, P QRS missing, P wave here, P QRS missing. And this is the one we're going to be discussing next. Here's another example of that. P wave QRS, peak wave QRS, missed, missed. P wave QRS, peak wave QRS, miss, miss. And lastly, let's look at another example to kind of get this point across. Real nice. All right. P wave QRS, P wave QRS, P wave QRS, P wave QRS, and P wave, no QRS. P wave QRS, P wave, and so on. It's the dropped beat. And this one needs an atrial pacemaker, Mobitz type 2. PR intervals are constant, they do not elongate over time, and there is a sudden dropped beat. And the 2-to-1 heart block, which is the one we just saw right there at the very end. Because every other P wave is blocked, the EKG is in 2-to-1 conduction and does not show 2 consecutive PR intervals. So it is unclear whether the PR interval is increasing or actually staying the same. But if the QRS is narrow, we think that its 2-to-1 blocks are actually Mobitz type 1. And if the QRS is wide, then we think it's actually a Mobitz type 2. So you can see the P waves are hitting like right after the T wave here. So normal P wave, P wave, P wave, P wave, P wave, and so on. Here it's a little easier to see. Now here the QRSs are narrow, so we think this is a Mobitz type 1. High-grade second-degree AV block is present when 2 or more P waves are dropped consecutively. So a high-grade I did not want to do that. A high-grade second-degree AV block when 2 consecutive P waves are dropped consecutively is the most serious of all the arrhythmias of the second-degree block, and it can progress to full heart block. That means it's an unstable block. This is the example of a second-degree AV block with 2-to-1 conduction. The 12-lead EKG shows 2-to-1 conduction. So let's see here, you got your P wave in here, so it actually makes it look like a biphasic T wave, but it's not, it's just a T wave. It's in there with the T wave. So then you get your drop beat here. And then P wave, so drop beat here. So that's a 2-to-1 conduction, right? The other findings are the QS complex in 2, 3, and AVF over here, indicating a non-acute inferior MI, and the prolonged PR interval of the conductive P waves. This EKG can easily be mistaken for sinus bradycardia, since the second P wave can be overlooked, and I mentioned that already, as a biphasic T wave. This is actually a 2-to-1 second-degree AV block. This is a high-grade second-degree AV block. That means that 2 consecutive P waves are drops. This 12-lead EKG shows an AV conduction of ratio of 3-to-1, 3 P waves for every QRS, indicating that every third P wave is being conducted, resulting in pronounced bradycardia of 32 beats per minute. The QRS complexes are wider than normal, indicating the block is located in the bundle branches or the His Purkinje fibers. There is a right bundle branch block configuration to the QRS. It's too wide. It looks like a right bundle. There are deeply inverted T waves in the leads 1, a VL, inverted T wave, V2 through V4. High-grade AV blocks advance to third-degree blocks without warning, so artificial pacing should be instituted without delay. And third-degree AV blocks, total interruption of the AV conduction system. The hallmark is regular P-to-P intervals, unrelated to regular RR intervals. That means the P's march, there are equal lengths, P to P waves, and R2R waves march, but they don't correspond to each other. That means that there are two independent pacemakers going on, the A node and the AV junction. The most common cause is age-associated fibrosis of the AV conduction system and myocardial infarction. Heart block caused by inferior wall MI may subside after the edema resolves in 1 to 2 days after the MI. In this third degree, complete AV block, complete AV dissociation is shown in all three tracings. P waves march through the QRS complex, so they march. So that means every distance from P to P is the same. And every distance from QRS to QRS or R to R is the same. But they don't correspond to each other. So that's the hallmark of a complete or third degree AV block. The QRS complex tracing A and B have wide and distorted shapes. In tracing C, the QRS complex are narrow and occur at a faster rate than the previous tracings, confirming the junctional escape region. So it's happening higher up in the heart. That way the QRS looks more normal, but it's still a heart block. And type C reveals an acute injury pattern. That means like acute MI because it has an ST elevation. You can see the ST segment right here. It's elevated compared to the baseline here. So that's like a 2 to 3 millimeter ST elevation. So in the context of acute MIs, you can get complete heart blocks, but these can resolve a couple days later. But this patient might need temporary pacemaker placement. So sinoatrial blocks is the sudden loss of sinus activity, missing the P and QRS complex altogether. Either the SA node fails to fire or the impulse is blocked by whatever. Patients have history of syncope or weakness or lightheadedness, so they are symptomatic. Sinus pauses are terminated by an escape beat. So not a drop beat, but an escape beat. Something else takes over. They are classed, the sinoatrial blocks are classed as incomplete when there's occasionally sinus impulse is dropped, and complete when no P waves are visible with the escape rhythm. So this is an example of a sinus arrest. This tracing shows simultaneous records of leads 2 and 5. The first two beats have P waves, P wave, P wave, and there's wide QRS complex, at a rate of 40 beats per minute. The pause lasts for almost 6 seconds, that's that there, causing syncope. The failure of backup pacemakers in the AV junction or his Purkinje system indicates widespread pacemaker dysfunction, and a transcutaneous pacemaker resulted in one-on-one capture until permanent pacemaker could be inserted. So this patient actually needed placement emergently of a pacemaker because of the risk that sinus arrest becomes a full cardiac arrest. And this is another example of sinus arrest. You got the normal PQRS, 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 P, nothing. Well, actually, that's not a P. That's a T wave, I'm sorry. No P, and pause, and then again. So it almost looks like Bainbridge reflex. You get a normal sinus arrhythmia when you breathe in, your heart slows. When you exhale, the heart rate goes faster. So you can get a difference where the P, QRS complex to each other are a little widened, but this is more than that. And that is a 2.5 second pause, and that is a sinus arrest or sinoatrial block. And finally, sixth sinus syndrome, SSS, actually is a grouping of dysrhythmia. It alternates between Brady and tachycardia, therefore is also known as tachy-Brady syndrome. You can see the episodes where it's tachycardia and then bradycardia or pauses. And this is a cool one. And this is actually very symptomatic and definitely needs treatment and assessment. And that's it for today. This is the video for Good Friday. I hope you enjoyed. This one is worth watching again and reviewing. There's a lot of little details, a lot of little things that you need to memorize so that when you see these, you recognize it. We talk about the AV blocks. We talked about first, second, and third degree AV blocks. We talk about sinoatrial blocks and sinus arrest and sixth sinus syndrome. So I hope you enjoyed this video. I hope you learned a lot. I hope you have a great weekend We'll see you in our next video. Bye-bye.